Okay, I can start. Good morning. My name is Prathap Tharyan. I'm a retired professor of psychiatry at CMC, but for many years I've been involved with trying to use evidence to inform health policy.
Can just say some things, just for 1 or 2 minutes, so that we can read the. Wait for 2 minutes.
Sure. What do you mean? Nobody come like this?
Session has started.
Yeah, but they're not there, no?
Yes, ma'am.
Nobody will be able to see.
People are coming.
Yeah, now I can.
Yes.
Hi, Chanukya. Good morning. My name is Prathap Tharyan. I'm a retired professor of psychiatry at CMC. Right now, I'm adjunct professor with the clinical epidemiology unit. Good to see you. Just tell me if you can't hear, just type a message. If you can hear me and you can understand the speed at which I'm talking, that's okay. Is that okay? Can you hear me and am I speaking too fast? Right, so I presume that you can hear me. Good, okay. I'm going to start and you can interrupt me anytime by typing any questions. So what I'm going to do today is discuss with you, I've been given 2 lectures to take for this course. One is, and they're in 2 parts. And the issue is, what is the relevance of all the epidemiology that you may learn, and how do you integrate that into clinical scenarios? That's the overall objective of both sessions. But today I'm going to talk to you specifically about how do you assess whether the results of research studies will have clinically important and clinically appreciable benefits in terms of efficacy, effectiveness, and efficiency. That's one of the main things I'm going to talk about today. Then the next thing I'll talk about is how do we know that we can actually trust the results of these so-called studies? And what we mean by this is the internal validity. And finally, we will talk about how do we decide whether these results are actually applicable to you. That's what we call external validity. So main 3 questions I'm going to address today is, how good is this intervention in real life based on what the study says? And the next thing we want to find out is, can we actually trust these results? And the third thing is, can we use these results? Fine, so let's start with how do you decide whether an intervention which has been reported in research studies actually has any clinical benefit. So the 3 measures are efficacy, effectiveness, and efficiency. And what we mean by efficacy is, how does this drug or a non-drug intervention or a procedure or a program perform under ideal or other controlled or in a pilot situation when you're looking at it as an experiment? Does this work, and how well does it work? That's efficacy. Once you've decided that an intervention works, then the next question is, how will it work in the real world? Or when you scale it up from your pilot study? What are the effects under the real world conditions? And that's really what we want to know, but we need to first be sure that it works under controlled conditions. And the next question we want to ask is, how efficient is this in achieving what we need? Is it cost effective? What is the cost benefit ratio when you start using it in the real world? And when we talk about costs here, we're not only talking about money, but we are also talking about discomfort, pain, absenteeism, disability, and social stigma. So the 3 things are efficacy. Does it work under ideal circumstances? Effectiveness. How well does it work in the real world conditions? And the third question of efficiency is it cost effective in terms of money and all the other things that are important to people? And this cost includes direct and indirect costs. Direct cost is actual cost of delivering the intervention. Indirect costs are what are the other costs of setting up the program for people to come, for the number of days lost from work, things of that sort. And it also includes opportunity costs, by which I mean, if you do this, this is the cost. But the money you use for this, what would you have used it for otherwise? And how does it compare? It's a lost opportunity. Does this give you that much more benefit that it justifies not doing the other thing? That's opportunity costs. So those are the three measures of looking at how effective an intervention is. Now let's just see, how do we measure outcomes? So sometimes in a program, you will be measuring certain things, but the issue is, are you measuring an indicator of the process, or are you actually assessing the outcome? Right. So for example, if you're doing the National Rural Health Program, can assess the effectiveness of the impact of that program by saying the number of doctors appointed in PHCs, the number of medicines given, the number of patients seen. Those are process indicators. It gives you an idea as to actually, is the program functioning well? But what you also will need to know is, what does it achieve? How many deaths did you avert? How many infections did you prevent? Things of that sort. The outcome versus the process. That's one issue to keep in mind. The second thing is, are you assessing proxy indicators, or are you actually assessing clinical outcomes? So sometimes when you're looking at, for example, the efficacy of an anti-diabetic drug, right, and comparing it with no treatment or some other anti-diabetic drug, you might say, my outcome I'm going to assess is the blood sugar value, HbA1c levels, right? And you'll show that one drug is better than the other drug in bringing down the HbA1c levels. That's good. But what are you treating these people for? Diabetes. Why? Sure, you want to bring down their blood sugar levels, but actually what you're trying to do is to prevent complications, prevent death, things of that sort. So those are the clinical outcomes that you want. And the biochemical outcomes are what you call proxy indicators, kind of substitute outcomes. So you might assess the efficacy of a vaccine program by the number of the coverage of the vaccine. But actually what you want to know is, among the people who got the vaccine, how many people did not get the disease you were trying to prevent? So those are things to keep in mind. Next thing you want to think about is, are you only looking at how good it is in saving lives, or are you also interested in how safe is it? How difficult is it for people to follow the treatment? How does their life change in terms of that? And the cost. So you need to keep in mind that the effectiveness of a program is determined by a balance of all these different kinds of outcomes. Then the other question is, how do you decide on what outcome to use, even for efficacy? Is it decided by the researcher or the clinician or some other service provider, or is it decided by the administrator or the patients or the families of patients? So ideally, you should be able to provide outcomes which everybody will find useful. So there's now a great emphasis on saying that you must consider also reporting outcomes relevant to patients, important to patients and their families, apart from just outcomes that you want to know as a researcher or a clinician. And then when you're measuring these outcomes, you have to pay great attention to how you define them. So when you say, I am defining relapse, you must have a clear, measurable way which can be standardized to say, this is what is meant by relapse in this condition. And then when you're assessing the outcome of relapse, if it involves a clinical examination or if it involves a blood test, you must be sure about the validity and reliability of these assessments. Then the next question is, when you're saying this is good, you need to have something to compare it with. Good compared to what? So these need to be clearly defined when you're trying to assess or measure an outcome. So let's start with this case study that I'm going to go through for some time now on how you can find and use evidence to answer clinical problems. Okay? So this problem involves a person I knew when I was a child. And she contacted me many years after we had separated and gone different ways when I was a consultant in clinical psychiatry. And she called me saying that she's a journalist now working in Bangalore and is now pregnant. She's in the last trimester. She's expecting to deliver fairly soon. This is her second pregnancy. And the first pregnancy ended unfortunately because the child was born, the neonate was born prematurely because it had immature lungs and it developed a condition called respiratory distress syndrome and it died. So this second pregnancy was very important for her because she wanted a live child. But her doctor told her that she's at high risk of delivering prematurely again. And his advice to her was she should consider trying a short course of corticosteroids to prevent neonatal death. But since my friend was a journalist, she knew that steroids also have some adverse effects and she wasn't very sure it's going to really help. That's why she called me and said, is there any evidence or can you tell me, should I take this treatment? So I tried to ask my colleagues and professors and they weren't really very sure. So I decided I will try and find the answer for myself. I will consult PubMed. That is the National Library of Medicine is available online and it gives you the results of various journal articles. And there are hundreds and thousands of these journal articles since the mid-50s or 40s. So I have to search through all these articles to find the answer to my question. So the problem then is I have to be able to be clear what exactly I am asking. So the first step in trying to find an answer for a clinical question based on some research study is to phrase the question, rephrase it in a way that can be answered. Right? So I could rephrase it by saying, okay, my question is, in mothers at high risk of premature delivery, will a short course of corticosteroids compared to no steroids reduce or prevent neonatal deaths? That's during the neonatal period, the first few weeks. So what I've done is I have framed it in the form of a PICO statement, P-I-C-O-T-S, where P stands for the population I'm interested in, I stands for the intervention I'm looking at, and C is comparison. Here it is no steroids. And the outcome I've chosen is neonatal death, but you could have many outcomes. You may have a primary outcome and secondary outcomes. Then you also want to ask, when am I measuring the outcome? Immediately, many years later. So in this question, I'm immediately after birth, in the few weeks after birth. Having answered this, phrased it this way, my next point is, what is the best study design that can give me an answer I can trust? So when it comes to interventions, the best design that doesn't introduce bias or rather doesn't give you wrong results is considered to be a randomized controlled trial. And so what I did was in PubMed, I put in the words for searching premature delivery plus steroids. And I looked to see whether I can find any articles which are randomized trials, which have assessed steroids versus anything else in mothers at high risk of premature delivery. And I found this article. It was published in the journal called Pediatrics in 1972, and it was authored by various people. The first author is a person called Liggins. And the title of the study was a controlled trial of antepartum glucocorticoid treatment for prevention of the respiratory distress syndrome in premature infants. This looked like an interesting study because it seemed to be answering my questions. So when I read the paper, I found that it was reported from Auckland in New Zealand in 1972, where they had reported the results of a randomized controlled trial where they randomized mothers who are due to deliver preterm, they're all high-risk pregnancies, to get steroids or not get steroids in a random allocation. And their main outcome was neonatal death. So clearly this is what I was interested in. I was eager to read the results. And here are the results. What you've got here is what is called a standard 2x2 table, where we're looking at the number of people who died or did not die. In the mothers who got steroids or did not get steroids. The plus is the number of mothers who got steroids or the number of children who died. So here, 532 mothers were randomized to get steroids, out of which 36 neonates died and 496 did not die. That's A and B. Then you had 538 mothers who were randomized not to get steroids. They may have got a placebo, in whom 60 neonates died and 478 did not die. So if you look at this, it certainly looks like there is an apparent difference in the results. But our Right. I'm sorry. There was a loose connection here, so it seems like you were not connected for a while. So I'll go back and recover the ground that I was talking about. And I hope you can actually hear what I'm saying. So this is the case scenario that I had started with, saying that there is a person who I knew in childhood who contacted me when I was a clinician, just a junior consultant, saying that she needed help with a medical problem that she had. And the problem was that she was pregnant again, second time, and she was in the last trimester, just going to deliver. And she'd lost a child in her previous delivery because the child was born premature and the lungs were not matured and the child died. And her current obstetrician told her there is a high likelihood that this can happen again because you're still a high risk pregnancy. So if you want to prevent the child from dying of respiratory distress because it's not matured, why don't you try a short course of steroids? Because there was some belief that steroids can make the lungs mature faster, and that will help prevent the child from dying. So her doubts were, will steroids actually help or will they harm? And that's the question she wanted me to answer. And when I could not find this answer from talking to my fellow consultants, I actually thought I'd try and find the answer by looking for it on PubMed. Now, when you want to try and search for something on PubMed, you need to be able to phrase the question in a way that you can actually find the answer. Otherwise, you just write prematurity or something, you get a lot of answers, and it'll take you a long time to find what you really want. So one of the things we have to do is frame exactly what are we looking for. So I could reframe the question as, in mothers who are due to deliver, will a short course of steroids?
This will allow you to see if you're logged in or logged out. So where? How do you know? Are you logged in or logged out? Yes.
Can you just type and let me know whether you can hear me and can you see me? Can one of you just type and say, yes, we can see you or we can hear you? Yeah, we can. Great. Fantastic. Okay. So I'm framing the question in a way that we can answer it. So in mothers at high risk of premature delivery, great. Will a short course of steroids compared to no steroids prevent or reduce neonatal deaths? So what I've done is I've framed it in the form of a PICO statement. P stands for population, mothers at high risk of delivery. The intervention is steroids. The comparison is no steroids. And the outcome I'm interested in is neonatal death. And you may also want to know, when are you measuring the outcome? In this case, it's in the neonatal period, shortly after birth. But it could be at 6 months, at 10 months, whatever it is. And you also want to type in what kind of study design am I looking for? So here I know that for comparing two interventions, the best design to give me an unbiased answer is a randomized controlled trial. So I include the word randomized controlled trial in the filter when I'm searching. And having done that, I found this trial reported in Pediatrics in 1972, which seemed like what I wanted. And when I read the article, I found that they had randomized mothers who are going to deliver preterm to get steroids or not get steroids. And one of the outcomes, their main outcome was neonatal death. And the results showed that in 532 mothers who were randomized to get steroids, 36 neonates died and 496 did not die. And in 538 mothers randomized to get steroid, 60 neonates died and 478 did not die. So the question for us, there seems to be a difference, but is this difference important? And how will you find out? So what we are trying to say is, how do we know that this difference in the outcomes could have not happened by chance? So traditionally what you do is you have something called the null hypothesis. Null means no difference. And you interpret the difference using the p-value or the probability value. So in this null hypothesis, we start with the assumption that there is no difference in mortality or with steroids or with placebo. And we want to test to see whether this difference is important, is due to chance or not. And you'd use a chi-square test, which is a test for the difference in proportions. And it evaluates whatever difference you've seen, is this what could be accounted for by chance, or is it more than what you'll get by chance? And if you get more, if it's more than what you get by chance, you can see the probability of how much better than chance is it. So if we say you get a p-value of less than 0.05, that is conventionally considered a statistically significant difference. And in fact, if you do any kind of statistical test, like the t-test, which is comparing the means and standard deviations between two groups, say for example, the mean weight or the mean height, you will get a p-value. If you have more than two groups, like 3 or 4 groups, you'll do an analysis of variance across the groups. Or if you're correlating whether higher doses gives you better outcomes, you can get a correlation that also has a p-value. Basically, the p-value is telling you the probability of seeing that difference. Is it due to chance or is it greater than what you get by chance? So let's look at it very carefully, what exactly the p-value denotes. So the p-value basically tells you how certain are you difference in outcomes is due to chance or is not due to chance. I've heard a noise. I'm wondering whether I'm still audible. Can you still hear me? Can you hear me? Can you see me? Is it connected? Okay, fine. So we want to know whether it's due to chance or not due to chance. If you get a p-value of 1, it means you're 100% sure this difference is due to chance. It's not a real difference. If you get a p-value of 0, it tells you that you're 100% sure this is not due to chance. This is a real difference between the two outcomes. Okay, then what do you do if you get a p-value of 0.5? You don't know. It could be chance, it need not be chance. What do you get when what do you interpret when you get a p-value of 0.1? It basically means you're 90% sure this difference is not due to chance. Degree of independence. I didn't understand that. What do you mean by degree of independence? It basically tells you, the p-value tells you, is it due to chance or not due to chance? So if you get a p-value of 0.1, it tells you you're 90% sure this difference is not due to chance. That's right. That's right. Perfect. So if you get a p-value of 0.05, right, that's right. But basically, I'm trying to tell you that I want to know, is it due to chance or not due to chance, right? Is it true difference? So p-value of 0.05 just tells me that I am 95% sure this difference is not due to chance. And if you get a p-value less than 0.05, you're more than 95% sure this difference is not due to chance. So now that's clear, I'll give you another scenario. I'm giving you rows and columns. And in the first and the fourth row, I'm talking about the numbers in the treatment group and numbers in a control group, where the sample size changes from 5 to 10 to 15 to 20 to 100. So if I look at the response in those two groups, it tells me when I have a sample size of 5, 4 people respond in the treatment arm, and then the response rate is 4 out of 5 is 80%. And in the control arm, out of 5 people treated, 2 responded. That's 40% response rate. And if you keep looking at the response rate, whether it's 5, 10, 15, 20, or 100, the true response rate shows that the treatment arm is double in terms of response than the control arm. However, if I try to look at the p-values, when I have a p-value of 5 in each arm, the p-value is 0.29. So it's about 71% sure that this difference is not a chance difference. When I increase my sample size to 15 in each arm, just 30 people, but because the difference in the efficacy is so much more, double in one group compared to the other, there's a big difference. With a small sample size like 30, I am now 97% sure this difference is not due to chance, because 0.03 is 97% sure this is not a chance result. But when I increase my sample size to 100 in each arm, I get a p-value of less than 0.001. And usually the paper will report this is highly significant, the p-value. And it's trying to imply, or people can interpret it to mean, this is highly important, the difference. Actually, it does not mean that at all, because even with a p-value of 0.29, this difference was highly important. But because the sample size was too small, you could not demonstrate it statistically, right? So that's called a type 2 error in statistics. Basically means there is a real difference between these two treatments or these two conditions, but because the sample size was too small, I could not show it. Right? So anytime you find that the results of two groups are not showing what you call statistical significance, first question to ask is, did they have enough of a sample size? But let's look at the opposite of that. When you have 100 in each arm, you get a highly significant difference, statistical significance. But I can give you a p-value of less than 0.001, even if the difference between the two interventions is only 1%. I'll show that to you. Take a look at this. This shows you drug A and drug B for treating people with a depressive episode. And on the vertical axis, you have the percentage of patients in remission. That means they are not depressed at the end of 6 weeks. And if you look at the values, the difference between drug A and drug B is about 1%, 30.5% versus 31.5%. But this p-value is less than 0.0001. And it can happen if you've got a very large sample size. So you've got a statistically significant difference by your p-values. But the proportion difference is only 1%. It's clinically unimportant. Right? So the take-home message from this bit is that any observed difference between two groups, no matter how small, can be made statistically significant at any level of significance by taking a sufficiently large sample size. Therefore, p-values do not tell you how effective the intervention is and whether this is clinically important, but it only tells you that this difference is not due to chance. So the major thing I want you to take home is there's something called statistical significance demonstrated by the p-values, and there's something called clinical importance. Now, traditionally, in most of the papers that you read, you'll find that people assess the importance of one drug over the other drug difference by the p-values. But it will not tell me whether this drug, it'll tell you the difference is not significant, but it won't tell me how much better is one drug compared to the other, or steroids compared to no steroids, which is what my friend needs to know. Remember, this is about my friend. So how do we then assess it? We got to see how can you assess the clinical importance of study results. So here we use a method called estimating the effect rather than testing a hypothesis. So commonest. Thank you. Good. I hope the rest of this is also important to you. So I'm going to transfer from saying p-values to say what else can we do. So now I'm going to tell you what exactly a relative risk means. And I'm giving you an example of a fictitious trial where you had coconut tree climbers from Tamil Nadu competing with coconut tree climbers in Kerala. They're competing. One group says they're better than the other. So they had this little experiment to see among the Tamil Nadu coconut tree climbers and Kerala coconut tree climbers, who's better at climbing coconut trees without falling down. So here, in this experiment, you had 164 people from Tamil Nadu climbing, out of whom 119 fell and 45 did not fall. And then you had another 165 people from Kerala climbing, out of whom 130 fell and 35 did not fall. So if you look at those results, there is a difference. Actually speaking, if you look at the results, both groups are useless because more people fell than did not fall. But leave that. Within this group, which one is better? You can do your chi-square test and get a p-value. But you can do it another way. You can say, okay, what is the risk of falling in the people from Tamil Nadu? So 119 fell out of 164 who climbed. That's right. That's right. Event, what I mean here is if 164 people climbed, 119 fell. That's the risk of the event in the Tamil Nadu arm. And the Kerala arm, it is 130 people fell out of 164 who climbed. So the risk ratio is one risk divided by the other. And it gives you your value for the risk ratio. The risk on treatment, there is a proportion with event on treatment by the proportion with event on the control treatment. So that's your risk ratio. Now, there's another way of looking at it, it's called the odds ratio. That's not the same as risk. Here it is the odds of falling or not falling. In the Tamil Nadu arm, 119 fell, 45 did not fall. And the odds of the event in the Kerala arm, that is 130 by the people who did not fall. So you get a different metric or value. That's the odds ratio for this. Odds here is the probability of the event versus no event on, that's right, the ratio of probabilities of falling or not falling in both the treatment and control arm. Now to interpret it, you can get two things you'll get out of this. One is which intervention is better. Now in a trial, or even anyway using an odds ratio, one means, or risk ratio, one means there's no difference. But in a randomized trial, if you frame your outcome in a negative way, that is death, relapse, not improved, these are not desirable outcomes. Anything less than one, like for example 0.42, means that the treatment is better than the control. The experimental intervention is better. If it is more than one, the control intervention or the experimental intervention is better. The experimental intervention is harmful and control is better. So here, depending on how you frame the outcome, is it desirable, undesirable outcome, anything less than one, the experimental treatment is better. If you frame it the other way around, alive or improved, then the interpretation is reversed. So if you get 0.42, it means control is better. 1.42 is the treatment is better for a positive outcome, a desirable outcome. So one thing it tells you is which one is better. What it also tells you is how much better is it. So if you get a relative risk of 0.42, it means that treatment reduces the risk of the negative outcome by 58%. It's called the relative risk reduction. 1 minus the relative risk. Or you can even think of it and say 100 minus 42, if you want to express it as a percentage, right? And if you get a risk ratio of 1.42, it means the intervention increases the risk of the negative outcome by 42%. Okay. So it tells you, you can quantify the important. Could we quantify degree of favor in these ratios, which is clinically relevant? I'll come back to it. I'm just coming to that. So I'm talking about what all can you learn from a relative risk or an odds ratio. You can find out which one is better. You can find out also how much better is it, right? So if it is 42% reduction in the risk of death, then clinically you'll have to ask yourself, are you happy with the 42%? And I would think, yes, 42% is very good. And now let's compare these two metrics, risk ratios and odds ratios. Okay? Odds ratios are mathematically more consistent. For example, an odds ratio for death and the odds ratio for being alive are just mirror opposites. That's because if you look at it, say the odds of death in 100 people or 10 people, 2 died. Right? So the odds of dying is 2 by 8. 2 died, 8 did not die. And the odds of being alive is 8 by 2. It's just opposite. So if you halve the odds ratio for death, then it's a mirror opposite of that on the other side. But for relative risk, it's not the same. You get a different relative risk for death and a different relative risk for being alive. The example would be, suppose you had 10 people, the risk of, and 2 died. The risk of death is 2 out of 10. But the risk of being alive is 8 out of 10. Different numbers, so they are not the opposites of each other. They have to be recalculated. So you cannot extrapolate it alive and death with risk ratios. You can do that with odds ratios. However, risk ratios cannot be used and also for case control studies, retrospective studies, when you're having two different groups. Can we use RR in case control studies? I'm coming to that point. You cannot use relative risk in case control studies because it's the population being treated, how many died, how many did not die. Here you have one group and another group. right? So you cannot compare two separate groups using risk ratios. You can compare them only using odds ratios, okay? But at the same time, if you have a prospective study like a clinical trial or a cohort study, you can use both. Yes, if you have a cohort or a clinical trial, you can use both. You can use odds ratios or risk ratios. But in general, risk ratios are easier for clinicians to understand than odds ratios. Because clinicians think, I treated so many people, so many got better, right? And clinicians tend to misinterpret odds ratios as risk ratios. That's in general, if you're looking at the results of a clinical trial, it is better to use relative risk than odds ratios because people understand it much better. Also, when you have very few events, the relative risk and the OR may be virtually the same number, although they mean slightly different things. So if you've got very rare events, you want to use odds ratios, the risk ratio also is likely to be similar to that. But as the event rate becomes more common, more than 10%, definitely more than 20%, then the OR and the RR differ considerably. And the OR tends to overestimate the effects. It will say it works very well, and the relative risk gives you a more conservative estimate, which is more likely to be the truth. So for common events, definitely use only relative risk. For you can use both. Okay, I still think we're connected. Good. I'm going on. If you have any doubts, this, please. Do you understand this bit? Okay, I presume you did. But the problem is these two estimates have to be accompanied by their confidence intervals because this experiment, very good. So this experiment, if you do it many times, you do it in Karnataka, you do it in Jamaica, you're not going to get the same relative risk. This latest study from NEJM, which one is that? Yeah, we'll come to that. We'll come to that. We'll be definitely looking at that later. I'll do that. Let me finish this talk because, I'll get to that link later. So I want to explain that commonality in what? How do we define commonality? What is commonality there? Of the event. I really don't understand what you mean, commonality. How common is it? Is that? I mean, the word commonality means how common is it? Right. So common means, example, 2 out of 10 is less common than 5 out of 10. So when you have rare events, you're talking about, say, event rate is 1% or 2% compared to a common event, which is, say, 20% or 30%. I'm coming to that also. I'm talking about that as well. Just hang on to that. Okay. So your confidence interval gives you an estimate of how sure you are that that is going to be the risk estimate. So from one trial, you can predict what it might be in other future events. Then how 95% of the time I can be sure that the relative risk will be a range of values in which my estimate will be there. So it's a measure of uncertainty. It tells you that the results of one trial is not truly representative of all trials done. It's also a measure of precision. So if you have a very large population, you're more confident of your results and you'll find that your confidence intervals tend to become narrow. Okay? But the precision comes in where is the range? Does it include 1? So if you've got a relative risk of 0.5, it means there could be a 50% reduction in the risk of dying. But if it's 1.25, it could also mean a 25% increase. So it's a very uncertain result clinically. And statistically, automatically, it is not significant. Your p-value will be more than 0.5. But if the upper and the lower limbs of the confidence interval lie entirely on one side or the other, that is 0.5 to 0.9 means your best estimate is 50% reduction, your least estimate is 10% reduction. It doesn't include 1. If your upper limit and lower limit are 1.2 to 1.8, your best estimate is a 20% increase. And worst estimate here will be an 80% increase. So because it doesn't include 1, your statistical significance is automatic. Your p-value will be automatically less than 0.05. Right? So this is a clinically important thing for you to know. Is it going to be harmful or not harmful? But how useful it is going to be in clinical practice is actually determined by the lower limit of the confidence interval, the limit closest to 1. Because if it is far away from 1, your greater likelihood that in the real world, where you don't control anything, you will still get that result. So if you're, in this example, I said 0.5 to 0.9, a 10% difference is the least estimate. But if it was 0.5 to 0.7, that's the least estimate is a 30% difference. So that's more likely to be a robust result when you use it in clinical practice, because it's a good intervention with the least estimate being at least 30% reduction in the risk of death. So that critical bit where exactly you consider a minimum important difference will depend largely on many things. One is it a adverse event like death, which you don't want at all, where even a 5% difference you may be happy to, you may not be happy with. And also it is likely to affect a lot of people. So in a public health intervention, a 5-10% increase in death is not something you're interested in. A decrease in death you may be actually happy with. But if it is things like, say, headache, which is a very subjective outcome, you need a much more clear evidence that this is effective for those kind of outcomes. We will come back to that later. So I'm going to move away from here and talk about my friend. So I would like you to help me with this. Can any of you tell me what is the relative risk to prevent neonatal deaths when you give steroids versus no steroids? Can you calculate that for me? Relative risk for the outcome of neonatal death, comparing steroids versus no steroids. Let's see who gets it first. Anybody got it yet? What is the relative risk? Not the definition. What is the actual number? You have to calculate it and let me know.
The screen person.
Anyone? 0.55. Okay. So what we are doing here is, if we were doing an odds ratio, we would be dividing. Yeah, if you were doing an odds ratio, it would be 36 by 496 divided by 60 by 478, or you could multiply, cross multiply. Here it is 36 by 532, 60 by 478, exactly. Now from this 2 by 2 table and this relative risk, can you tell me what is the risk difference or the absolute risk reduction? How will you do that? The risk difference, also called the ARR or RD. ARR is absolute risk reduction, RD is risk difference. Anyone? So that's right. So basically what you're doing is you're looking at the difference in the risks, right? So the risk in one arm is 36 by 532 and the risk in the other arm is 60 by 538. That's a risk difference. You can also use other calculations. And from that, the inverse of that is your number needed to treat. How many people would you need to treat with steroids to prevent one neonate dying compared to not using steroids. Okay. But you also need your confidence intervals. And although there are formulae for that, if you don't have this program, I think it's worth downloading it. It's called CI Calculator XLS, right? And it's a program sheet to find out confidence intervals for lots of metrics, mean, difference in proportions. Here, we want to see the treatment group and the control group, is there a difference? And what is the confidence interval for that risk ratio? So if you enter the numbers, 60 neonates who died among mothers who didn't get steroids, 538, 36 neonates out of 532 in the steroid arm, and you click on 95%, all your results are out there. It's a very useful program. You can use it for many things. CI Calculator.xls. What you now have to do is interpret this, right? So let's just take the risk ratio. Will anybody like to tell me how would you interpret this in a way you can communicate this to somebody else, like my friend? If I tell her relative risk is 0.61, confidence interval is 0.41 to 0.90, may not be able to clearly explain to her what I mean by that. I can convert this into English or any other language. So what is the RR of 0.61, 0.41 to 0.90 mean? Right. So what it tells you, right, if you use steroids, you reduce the risk of death by 39% compared to not using steroids. Your best estimate is, what's your best estimate? The best estimate is RR 0.41, which is a 59% reduction in the risk of death. Your least estimate is 0.90. Excellent, 59%. And 0.90 means you're expecting at least a 10% reduction in the risk of death. Right? So that's how we can see how important. Very good. Excellent. Now, what if your relative risk was 0.78 and your confidence interval 0.66 to 1.22? Is this useful? Will it work? Does it work? Your estimate is that there is a 12% or 22% reduction in the risk of dying. Your best estimate is that there could be a 34% reduction in the risk of dying. But your other estimate is that it could be a 22% increase in the risk of dying. So you don't know clinically whether it's going to help. And is this statistically significant? Anyone? 1.22 is not good. Right. So clinically, it's not a useful measure for you. No, it is not. Because it includes one, we don't know. Very good. What if it was, relative risk was 1.26, 1.06 to 1.39? Increases the risk. And because, is it, yeah, very good. Is it statistically significant? Clinically, you know, it increases the risk. I will not use it. It is statistically significant. Go on. You don't like the answer because it tells you there are a lot more adverse events. But because it does not include one, it is statistically significant. Right? It's not a chance difference. That's what it tells you. Okay. Now, I want to move on from relative effects, and I want to talk to you about absolute effects. Relative risks can be very impressive, but they can also deceive you. So if you can get a relative risk for death with intervention versus control of 2, right? It basically means there's a 100% increase in the risk of death with intervention compared to control. I can get this relative risk of 2 by comparing 1 death out of 10 people in one group and 1 death out of 20 people in another group. That's relative risk is 2. The risk difference, one risk minus the other risk, is 0.05, which means you have 5 more deaths per 100 with intervention compared with control. Okay? Risk difference. One risk minus the other death. 5 more deaths per 100. 0.05 divided by 100. How many out of 100? 5 more out of 100. I can get the same relative risk difference, or rather relative risk of 2 from comparing 1 out of 1,000 deaths and 1 death out of 2,000 people. Here the risk difference, one risk minus the other risk, is 5 more deaths per 10,000 with intervention versus control. So you see, same relative risk, different absolute benefit or harm. Why is that? Why do I get different absolute numbers compared to this in the same relative risk? Anybody? Sample size is different in both. It goes up equally in both arms, no? Okay. I want you to look at this concept of what is called baseline risk, which means what is the risk in the control group? Without the intervention, what is the risk of death? If you look at the first example, 1 out of 20 is the risk of dying in that group. That's pretty high compared to 1 out of 2,000. So it basically says that if your control group event rate or your baseline risk is low, even if the relative risk is pretty high, your absolute benefit is not going to be very high. Let me give you an example. Suppose one of you was very worried about the fact that you have a lot of pimples on your face, and you saw an advertisement for a pimple cream, which said that use this cream regularly for 10 days, and there'll be a 50% reduction in pimples. And you are very impressed and you go and buy this cream. But if you had asked the people who put that statement, how many pimples were there to begin with? And if they had said 2 pimples, 50% reduction is only 1 pimple went. But if they had said there were 500 pimples to begin with, a 50% reduction means that 250 pimples went. That's impressive. And if you ask the next question, is there anything left of the face? And if they say, yeah, face looks good, then you know this particular intervention is effective and safe. So the baseline risk, if it is low, the benefits you get are not very much. If the baseline risk is high and you got a good treatment, the actual benefit, the absolute benefit is going to be much. Right, so for example, we'd gone to Sri Lanka and we were trying to share, study with some of the public health students there, in which it showed that in countries, like India and Bangladesh and stuff, in children with diarrhea, giving zinc improves outcomes. So we asked them, do you think it will apply to you? And we told them, you first find out what the baseline risk of zinc deficiency is in your children. And they concluded very rightly, this evidence may not apply to us because in those countries, zinc deficiency is quite common in children. But in our country, zinc deficiency is not common in children. So if I give them a treatment like zinc, it's not going to make much of a difference to them because they don't need it. So your concept of baseline risk is important to understand whether the particular treatment is going to work. Younger people are not at much of a risk of getting heart disease compared to older people. So the treatments you use, you'll have to ask them, what is this person's risk of having a problem if I don't use this treatment? It's a good treatment for people who are at risk. That's the concept of baseline risk. The absolute effects, the number of people likely to die, depends on the control group or baseline risk. Relative effect doesn't matter. It's compared to that drug. Any doubts on this? Baseline risk and the absolute difference. If you do, just type your question and I can answer it. So when you have a low baseline risk, the number needed to treat is high. You need to treat many, many more people. You treat many more people to get benefit. So your baseline risk is 1 out of 2,000. Your number needed to treat is you have to treat 2,000 mothers. Inverse of the risk difference, right? When your baseline risk is 1 out of 20, your number needed to treat, inverse of that is 20. So the risk difference here is 5 more deaths, no? Inverse of that is 20. So if there's a treatment which is good, if it is given to a group with a high baseline risk, that risk multiplied by the relative risk is the absolute benefit. That's the relationship between baseline risk and your absolute benefit. Baseline risk, is it inversely proportional to numbers to be intervened for NNT? Yeah, in the sense that if you've got a low baseline risk, and I'll give you another example. Suppose you had a very powerful drug which reduces the risk of death from falciparum malaria by 50%. And you decided, I'll go and give it to in Geneva because that's where WHO is, they write all the guidelines. Am I going to get great benefit there compared to if I gave the drug in Africa? Clearly, I'll get more benefit with that same drug. I'll get more benefit in Africa, yes, compared to Geneva, because the baseline risk of dying from falciparum malaria in Geneva is 0. Right, so that's the concept of the baseline risk determines the absolute benefit, irrespective of what the relative risk is. If the relative risk may be good, you give it in a population which needs it, you'll get more benefit. Okay. So I'll give you an example here. The smaller the number needed to treat, the larger the difference between the two drugs. Larger numbers mean more patients needed to treat to see the difference in effect. So your baseline risk will determine their NNT. So looking at NNTs, if you get an NNT of 1, if one intervention has a 100% recovery rate or out, and the other intervention has 0, you'll get an NNT of 1, which is virtually impossible. Most of the time, you will not get an NNT of 1. But you can get an NNT of 3, which is a pretty large effect size. So if you're looking at the effect size in terms of mean difference and all, you will get a value of around 0.8. That will translate into an NNT of 3. You just need to treat 3 people with one treatment compared to the other to get one person to benefit. When you get up to 4, it's a medium effect size, and it corresponds to your effect estimate for mean difference for about 0.5. And an NNT of 9 is a smaller effect size. So when you start getting into double-digit NNTs, then it may or may not be very useful. It depends on what kind of outcomes they are, right? So let's look at the NNTs in terms of saying, in clinical practice, what kind of NNTs do you get, right? Anything within 10 is generally a good NNT. Anything more than 10, it may be good, but it depends on what the outcome is you're trying to prevent, like death. And if it's going to be very common, that outcome, even higher NNTs may be useful. So looking at this major depression drug, we talked about the difference of about 1% between the two drugs, right? And if you calculate your NNT for that, you need to treat 100 people to get one person to be better. On the other hand, if you found that the difference between the the treatments is about 10%, 30% versus 20%, right? Your NNT is the inverse of that. Your number you need to treat is only 10. So it talks about if you have a great difference between 2 interventions, you need to treat fewer people for benefit. If you've got a very little difference between 2 interventions, you need to treat a lot of people to find any benefit. So if you look at diabetes and you want to prevent neuropathy, right? Your NNT is around 15. If you look at an acute myocardial infarction and you want to prevent death over a 5-week period using streptokinase compared to aspirin, NNT is 20 for streptokinase. And if you look at respiratory distress syndrome or prematurity and you look at using prenatal corticosteroids, NNT is around 11. But NNT also depends on the individual baseline risk. Look at this. If you want to prevent death, stroke, or MI, giving people antihypertensive drugs for 5 years, your NNTs differ depending on what your diastolic pressure was. If it was 115 to 129, your NNT is 3. But if it was lower, diastolic pressure of 90 to 100, around 109, right? Like borderline almost. You need to treat 141 people to get a benefit compared to with our higher BPs. So that's the importance of thinking of, as we keep lowering our intake criteria for diagnosing, BP and sugars and stuff, they're starting to move towards people who may not really benefit that much from that intervention because those drugs are actually meant to treat people with actual disease. And these are like pre-disease. And you think in terms of getting a lead time by diagnosing them earlier, will I actually be able to prevent more? It doesn't work that way, as you can clearly see here. When your disease is not that good, severe, For milder people, you need to treat many more people to get one person to benefit. That has to be an individual decision for that person because he may not really be at that much risk compared to people who've got a higher value. If you have any doubts on these issues, just type it and I can try and answer that. I'd like to move on and summarize what we just did so far. OR and RR are effect estimates. They're much better than using p-values because they tell you how effective an intervention is compared to the other. Absolute measures actually tell you the actual benefit you'll get from that, but this depends on the baseline risk of the intervention, right? Odds ratios and relative risks are not the same thing unless the event rates are very small, very few. Then they look the same. You can use it as an approximation then, although they don't mean the same. Confidence intervals give you an estimate of uncertainty as well as precision. Because uncertainty means that if it crosses 1, then your p-values are not significant. Certainty means that it doesn't cross 1, that it works or it doesn't work, and your p-values will be significant. And the importance of the difference depends on how far away from 1 is a lower limit. You know, how sure are you that in the real world, you will get the same effect as you got in the controlled experiment? You can do that by looking and saying how far away from one is. So now the question is, this is about my friend. What do I tell my friend? I can use the relative risk and say the Auckland study showed that a moderate risk for steroids from this 1,000 sample study, the risk is reduced by 39% compared to not taking steroids. The worst case is 10%. The best case is 59% risk reduction. I could tell her the treatment with steroids would prevent 4 less neonatal deaths per 100 births than treatment without steroids. 1 to 8 less. 4 less means 0.44. 0.044 divided by 100 is 4.4. Rounded up, you get 4 out of 100. And you can do the same for the confidence intervals, right? Or I could tell her that you need to treat about 23 mothers with steroids to prevent 1 neonatal death due to prematurity. Could be as few as 12, could be as much as 104. Which would you choose? Risk ratios, risk difference, or number needed to treat to benefit? What would be your preference? They're all the same data, but they're presented in different ways. So let me tell you that, you know, there's a study which looked at the preferences of people. You prefer risk ratio. Okay. Most people will prefer, most clinicians and patients like the risk ratios. But policymakers and people who want to spend the money, they may want to know, yes, risk. So managers and want to know how much actual benefit will I get. So my money I put into it, I can see benefit. So they prefer risk differences and NNT. But whatever it is, on the same 2x2 table, you can calculate all of these. Let's now think that I'm actually going to tell my friend, because I have to decide. I found the evidence and it's statistically and clinically important. Can I tell my friend to use steroids? It's disconnected. Loose cable. Huh? Now, can you hear me? Okay, so will you recommend using steroids? Can I tell my friend to use steroids? What do you think? Should she use steroids? Okay, so you're basing your results on the fact that this is an effective treatment. The next question you have to ask is, can you trust this result, which is what is called internal validity? Only then can you say, can I use the result, which is external validity? How do I know that that relative risk and confidence interval actually is a true value? Or could it have been influenced by various things? So that's the next step, internal validity. So assessing internal validity basically means we're looking to see what are the factors that can affect internal validity. Anything that can take away the conclusions from the truth. It could be due to what is called bias. something in the methods, systematic errors in the methods, including not looking for confounders and all, that can give you wrong results. Or it can be due to chance, random error. Random errors, we know how to find out because we know whether it's due to chance by looking at sample size, increased p-values, confidence intervals, etc. But bias cannot be estimated by using p-values. Right? We need to know what are the methods used so that there is no bias. Okay? So in this situation, I had to go back and read the article to see how did he do the study. It's a randomized control trial. Did he do all the things he should have done so that I can be sure there is no bias, there's no wrong result, right? So looking at a randomized control trial, there are various things we can do to find out. What we're trying to do is prevent selection bias. Okay, now to prevent selection bias, we randomize. And we are randomizing because we want to ensure that everybody who comes has an equal chance of getting steroids or no steroids, and also that we are balancing prognosis, that all the prognostic confounders are all balanced. Known and unknown confounders are balanced. That's why we randomize. And we can randomize using many things. We can randomize using tossing a coin. I can go to a computer and ask, I want 200 people, right? So I want to give you an example. We are going to design a study where we want 200 children randomized, 1:1, children with mild to moderate community-acquired pneumonia. And we want to compare 5 days of antibiotic versus 3 days of an antibiotic. And this is an actual trial which took place in India. So I've got a randomization code which I got from a computer. Basically, it's a long list which says 3 days, 3 days, 3 days, 5 days, 5 days, 3 days, 5 days. It goes on like that. There are 200. 100 get 3 days and 100 get 5 days. And now what I'm going to do is I'm going to give it to my nurse and say, you sit here with this list. And as people come towards you, we will send them, mothers and children, because we selected them and they've agreed to take part in the trial. You just assess that they have agreed to, they understand this is a trial and given consent. And then you look at the list and say, okay, this is next one is 3 days. Write on a piece of paper 3 days and go to the pharmacist. And the pharmacist will give you 3 days of medicines. And the next one maybe 5 days, you write 5 days in. Is there a problem with this? So what she's doing is she's recruiting participants using the randomization list. Is there a problem with this? Or is it okay? What do you think? Is this fine? Okay, let me tell you what can happen. Around 10:30 in the morning, this nurse is getting ready to go and have coffee. And she looks down and she's the next one on the list is 3 days. And just as he's going to get up, she sees, oh, poor Kavita is coming towards her. Kavita is a sweet little child who's been brought by her mother. Her mother works for all the nurses and she lives down the road where the poorer section starts. And that child clearly looks like she's got pneumonia and she's coming to me and she looked down and you see she gets 3 days. The next allocation is 3 days. So chances are what she'll do is because she wants to help the child, she's not very sure 3 days is that good. So she may just ask the mother to come with her for a cup of coffee because she knows the next one is 5 days. And when she comes, she knows there's another lady who's coming whom she can give the 3 days to. Is there a problem with that? Anyone? What do you think? Right. So what you mean is it creates selection bias. How is it going to make a difference? I didn't promise you equal numbers of kavitas. And when you randomize severe, moderate, and all, there's no severe, only mild and moderate. They will all fall on both sides. So how does it matter? You're right. But what exactly will happen if we allow her to have a say in who gets into which arm? I gave you a clue. I told you that the mother and the child live down the road where the poorer section starts. Poverty, poor children have a higher chance of dying of pneumonia. It's an independent confounder, right? This nurse didn't think of that, and therefore she changed the randomization sequence. So what randomization does is it balances confounders, right? So known and unknown confounders. So if you start moving people around without your knowledge, the confounders get unbalanced. And that may be the reason why one treatment is better than the other. The other important thing to keep in mind is randomization means unpredictable. You should not be able to predict who's going to get what. That is why you have to have this second component of randomization to prevent selection bias, concealment of the allocation. So in this example, how can you conceal allocation? Any idea? Have you heard of this? Okay, let me tell you this. So what we could do is put the allocation 3 days, 5 days, 3 days, whatever, in an envelope, serially numbered and sealed, and they should be opaque. Paper should be folded so no one can look. So she sits with a stack of envelopes. That serial number corresponds to 3 days or 5 days. That randomization sequence is separate. She does not know it. So when Kavita comes, she just takes the first envelope or whichever next envelope and give it to her. And that goes to the pharmacist. That's called concealing allocation. So the person recruiting does not interfere with the trial. Then when you go to the pharmacist may open it and find not 3 days, 5 days. He may find 2715, a code. And he looks at the boxes he's got for 2715 and uses one of those boxes, which is either 3 or 5 days. So that's how you can clearly prevent selection bias, by ensuring nobody has access to the code apart from the person who did the randomization, and that person is not involved. I thought you would say that. No, allocation concealment is different from masking or blinding. Now, what happens is when the mothers get the box, those two mothers have been given the boxes. They both open it and they find one mother finds 3 days of medicines and the other one finds 5 days. There the problems can start. So we don't want them to know what is inside it. So then we try to mask the interventions or blind the interventions. So what we can do is put 2 more days of dummy, placebo, antibiotic, right? But then what we have to very clearly do is pack them separately. So the first packet has got 3 days medicine, second packet has got 2 days dummy or real medicine. And this has to be explained in the consent form, that in the first 3 days, everybody will get the same antibiotic, but after that, we don't know whether you need more antibiotic. So half of you are going to get something which is not the antibiotic, looks like the antibiotic, not the antibiotic. That is called masking. Okay, and what masking does or blinding does, it prevents performance and detection bias. Okay, so another thing to just mention is that when you say double blind, it's very difficult to understand exactly who's blinded. Because some people will say patients should be blind, they should not know, and the treating team should not know, or the investigator should not know. The problem is, really a double-blind trial should be a triple-blind trial. Patient should not know, the people giving the treatment should not know, and the people assessing the outcome should not know. So the current recommendation is, don't use words like double-blind. Say who was blinded. The participant, the care provider, the outcome assessor, the data entry operator, whoever it is, explain that. Okay, next thing I need to make sure is that when I'm reporting the outcomes, I need to make sure that everybody is accounted for in the numerator and the denominator. So if I get a lot of dropouts in one arm and not many dropouts in the other arm, right, my results can be biased because the relative risk will change for that outcome. So there are ways which we have to figure out how to deal with it. They use intention to treat. I won't go into that, but you probably know that anyway. Then when you're reporting the outcomes, that all the outcomes that we said we would report, we actually report, and not only report the outcomes just statistically significant. So this is how you have to assess from the paper, has it been done well? Can I trust the results? Because there's clear evidence that if you don't do these things, your results tend to be wrong. It can be overestimates or underestimates. Again, to stress, allocation concealment is not the same as blinding or masking. Allocation concealment is a prerequisite to blinding. Without allocation concealment, you may not be able to blind, right? Blinding may not always be possible, like in a surgical trial, but you can always conceal allocation so that the surgeon doesn't choose who's going to get what operation. So allocation concealment prevents selection bias, and blinding prevents performance and detection bias. Okay. Fortunately for us, ligands was free of the risk of bias. Now, the question is, can we tell my friend to use medicine? What do you think? We've shown that this is a very effective intervention. It's for a very important outcome, and the results can be trusted. Shall we tell her to use the drug? What do you think? Yes or no? Any reply? Shall we ask them to use the drug? Okay. You could do that, but in clinical practice, when you want to transfer what you've learned from research, you have to ask other questions. And routinely in clinical practice, we ask these questions. Yeah, so there are many questions. One of them could be, how do we know that the drug which worked in New Zealand will work the same way in India? Some people will say, this study was done in New Zealand. It's not been done in India. So the answer to that is, ask yourself, is there any biologically plausible reason why women won't respond to steroids in New Zealand compared to India? I couldn't think of any. So that checkbox has been ticked. The next thing is what you ask, is it safe? The report didn't say anything about side effect, didn't say there were great side effects. But I asked myself, what are the potential harms of using corticosteroids short term? One is I could get gastritis, but I can treat that, not a problem. There could be an infection in the child. If the mother delivers in an unsterile area, steroids can increase the chance of neonatal sepsis. But I was clearly clear that this mother is likely to deliver in a good place because she took all this trouble to find out should she use steroids. So looking at the balance of benefits and harms, I think that's not a major problem. Is it affordable? Very cheap. Is it available? You don't even need the prescription. You can get from over the counter. Is it practical to take? There are no barriers, only a single tablet. I don't have to admit the person. I don't have to do any of that. Are there any other alternatives? Couldn't think of any. So this is the list of things that run through our mind to translate research evidence into clinical practice. And with that information, we can ask my friend, what would you like to do now? Having run through all these answers, we can do that. Now, shall we tell my friend to take the medicine? Rachna, what do you think? Yes. Injectable steroids, we can give it, whatever. But we can tell her to do this, no? But the problem I have is, how do we know that we have all the evidence? We don't know that. We only found one trial. And in the real world, it happens differently. There are other trials. So here I'm showing you the results of this ligand study in the form of a graph. The vertical line is a line of no difference. The horizontal line is the width of the confidence interval for ligands, and that blob in the center is the point estimate for the relative risk, 0.61, 0.41 to 0.90. You can clearly see that 0.90 is far away from 1. Shows it works. But here I have another study, smaller sample size, larger confidence interval, same PICO. Here the problem is it could even harm. So then it becomes difficult to interpret. I've got one study saying it works, another one saying, I don't know, may even harm. So that is when I came across the logo of this organization called the Cochrane Collaboration. And in the center, it's the results of a meta-analysis from a systematic review of steroids versus no steroids to prevent death due to preterm birth. Because they used a systematic approach and they had more resources, they found 7 trials. 2 of them favored steroids. One of them is the one we have, ligands. But they also have 5 other trials which shows may not work, may even harm. Now you have an issue because you've got 2 trials for and 5 trials against, or not so sure. So if you use the vote counting approach, you can make a wrong decision because this vote counting approach, 2 for, 5 not so sure, will do what? The 2 big trials, which had a lot of information, will be negated, balanced by 2 small trials. That doesn't make any sense. So what this organization does is they do a meta-analysis, which is they pool the data from all the relative risks are pooled together. So we follow guidelines which are formed after studying the meta-analysis. Yeah, exactly. One part of it. Meta-analysis is only one part of it. We'll do that in the next talk. I'll talk about the whole thing about systematic reviews and meta-analysis. But what this meta-analysis is doing is pooling the results, the relative risks of each of the studies, but giving more weight in the pooled analysis to the large trials like ligands. So they get more influence in the overall result. And if you use that approach, you can clearly conclude that steroids in preterm labor reduces the odds of neonatal death or the risk of death. I went and looked at an updated version of this review, and there's an even more updated version, but this particular version had now had 21 studies, a lot more mothers and children, and it gave me results which I had not even thought about. They said no risk to the mother and no risk of puerperal sepsis. But keep in mind that all these studies were done in high-income countries, and they were all hospital deliveries. So now there is some evidence that if you do these studies in low-income countries and don't pay attention to neonatal sepsis, that can be a problem, right? So where were those studies done? Will you get the same results here? Very clearly told you that the relative risk of neonatal death was reduced, and now they have more confidence. The confidence intervals have come down compared to what it was in ligands. So a clearer result that this is a good intervention. But it also gave me a lot more other results that I hadn't even thought about. RDS, cerebroventricular hemorrhage, necrotizing enterocolitis, etc. I want you to do one thing. Take a look at these results and tell me which of these results are statistically significant as well as clinically important. I think Chanakya asked me in the beginning, how do you decide what is clinically important? So let's do it this way. Take the first one, RDS. The risk estimate is 0.66. The relative risk reduction is about 34% reduction in the risk of dying. The least estimate is 0.73. That means at least a 27% risk reduction. Great, that is very good. It is clinically and statistically important. Cerebroventricular hemorrhage, the risk estimate is 0.54. The least estimate is 0.69, 0.43, right? So 0.43 is, 0.69 is the least estimate. That's a 31% reduction in the risk of dying. That's also very good. Necrotizing enterocolitis. The least estimate is at 26.74, is a 26% reduction in the risk of dying. That's also very good. But if you look at respiratory support and intensive care admission, the risk estimate is only 20% reduction. And the least estimate is 0.99, 1% reduction. So this is a statistically significant result, but clinically I am not so sure because the estimates are almost close to 1 because it comes from 2 small studies. So here I'm not very sure this statistically significant result is going to be clinically useful in the real world. Systemic infections, 0.85, 15% reduction. If it had been if it had been more than 25% reduction, I could clearly have said this is useful. At 15% reduction, I have to make a decision. Is this important for me? So here I'm introducing you to this concept and saying the clinically meaningful difference for interventions is something you have to set. What do you think you want? And it will differ across interventions and across outcomes. For bad outcomes like death, you may be happier with a smaller difference, closer to 1. But for subjective outcomes and things of that sort, you probably want to be more sure. Okay, so I will be discussing systematic in the next class in more detail. And if you have any questions, you can mention that, and I'll give you my email address at the end. You can even mail me. I want to move on to looking at the fact that for every question that you answer, there is an appropriate primary study which will answer the question. RCTs are for interventions if it's feasible and if it is practical to take. Yeah, I'll send it. I'll tell you what it is when I finish. I've got another 20 minutes left. Something more to cover. Now, any design, study design, has got a particular reporting guideline. So you need to go to the Equator Network, just Google it, and you will find the reporting guidelines for every type of study design. And the important thing is, if you are planning a study, you need to know how you should report it. Because then you can incorporate all those reporting requirements into your protocol so that you actually are able to cover all that. So for RCTs, it's Consort, observational studies, Strobe, systematic reviews, it's Prisma. For RCT protocols, it's Spirit. For diagnostic and prognostic studies, there are two, STAR-D or Tripod. For case reports, there is a reporting standard. For clinical practice guidelines, there is one. For qualitative research, there are two. Animal studies, quality improvement studies, economic evaluation. So every kind of design, there is a reporting standard. You can download all of them free from this particular website, Equator Network. Now I'm moving on to the results of systematic review comparing antidepressants, right? And this particular systematic review of 47 RCTs went to the FDA source and looked at all the new antidepressants that had been approved by the FDA. And all of them had placebo-controlled arm because the FDA requires at least 2 placebo-controlled trials. Approximately 80% of the response to medication was seen in the placebo group. And they found the mean difference between drug and placebo is approximately 2 points on the Hamilton Depression Rating Scale. And that's what the US FDA says you must have at least 2 points difference on the Hamilton Depression Rating Scale. And the problem is that the NICE guidelines, the UK, they want 3 points to show between drug and placebo. Then they will approve the drug. Okay, so I will just move on to this. My problem is this, no? Looking at what the regulatory agencies are saying, if you can show 2-point difference in the Hamilton Depression Rating Scale, you will get a statistically significant difference. But my question is it clinically important? Because when you have severe depression, your rating scale on the Hamilton Depression will be 53 or something. And when you are saying the person is not depressed, it should come down to 8. So I can drop my score from 53 to even 43 or even 33. Statistical significance will show, but clinically I'm still depressed. So the problem when you're looking at all these scale kind of outcomes which you get in mental health, in pain management and all, there are different kinds of rating scales. Hardly any clinician uses a rating scale. They think of it in a different way, right? But in research studies, you will find mean, standard, all these rating scales to get p-values. So the p-value here does not tell you, is this going to be clinically useful? It only tells you it is statistically significant, right? So what we need to do, as they did in this example, person I know, he looked at the whole BPRism, psychiatric rating scale, and said, this is not the way clinicians rate people who are ill. When clinicians rate severity, they'll rate mild, moderate, severe, and improvement as worse, no change, mildly better, moderately better, much better, completely well. That's called like the CGI scale. You'll say, how are you? I'm better. How much better? I'm better. In 1 rupee, how much better are you? 75% better. That's how clinicians think. So the CGI is a scale which looks at it like a Likert scale. And what he did was, he had lots of patients who had been rated on both CGI and BPRS. And he was able to therefore say what is mildly ill according to clinical impression and correlate that with the BPRS score. And he's also able to say what should be the drop in the score from baseline to say this person is clinically improved. Okay, so that's a very important thing to do. When you're trying to look at these continuous measures from scales, you need to be able to interpret what do these scales mean, right? Much more difficult to do than looking at your risk ratios and odds ratios. That's one of the things I wanted to talk about. And the other problem is multiple analysis. Some people will do what is called a subgroup analysis. They'll get one result and they'll try and look in subgroups to see what the analysis, to see does it work in this group, does it work in that group. And these are all observations, and you must be careful about your interpretation of these things because there could be some harms. I'll give you the results of this trial reported in the Lancet. It's called the VaxGen HIV trial, where they were looking at vaccines, efficacy for HIV, and they had 5,000 volunteers given HIV vaccine or placebo and followed it up over 3 years. And they found overall there's no difference in efficacy between vaccine and placebo. That's the result. But then they look to see whether it's any different between whites and Hispanics. No question, not significant difference. But when they looked at blacks and Asians versus the others, they found a p-value of less than 0.01 and showed fewer infections in blacks and Asians compared to others. And when they looked at only blacks, they found an even stronger p-value. Right? So this was the way they presented their results. And they had positive results for black people compared to the rest. And they even, this Lancet article even had another article talking to the inventor, who said this is the first time we have specific numbers to suggest a vaccine has prevented HIV infection in humans. But there could be a lot of reasons for it. So the problem was everybody thought this is not a positive trial, it is a rubbish trial, because the main result is not true. They're looking at all these subgroups. You can make mistakes if you do multiple analysis. Okay, another example. A subgroup analysis of a randomized trial of vitamin D supplementation between breastfed and bottle-fed mothers. And looking at the mean difference in serum calcium level, for breastfed mothers, the p-value is 0.4. Bottle-fed mothers, the p-value is 0.006. And they concluded that bottle-fed mothers is better than this. This is wrong. Wrong interpretation. You cannot look at the difference in subgroups with comparison of the p-values. There is a separate test called the interaction test. And you should directly compare these to that test. Anytime you do multiple tests, you will get a higher false positive rate. So for example, when you do one test, your p-value probability of a false positive rate is 5%. When you do two tests on the same sample, it goes up to 10%. By the time you reach about 10 tests, it's a 40% probability of having false positive results. Right? So whenever you do multiple analysis, be very careful, do very few, and those subgroups should be biologically plausible. And ideally, your study should have enough of a sample size to detect the subgroup difference, to be powered for those primary and secondary outcomes. Be careful about interpretation of this, right? You'll have to independently test it. And don't mention subgroup results in an abstract, because it's only a hypothesis. And only you mentioned in the abstract it was based on a primary study outcome. It was pre-specified. And you're saying this is number 10 of all the subgroup analysis you did. So people can know, is it likely to be a false positive? Last thing I want to share with you in the 12 minutes I have is the relevance of the outcome. Who decides what outcome is relevant? So I'm going to give you the results of two trials that we did in our department here, both reported. One is in BMJ and the other in the British and the Psychiatry. In both these trials, we were trying to answer the question, what do you do when you have disturbed patients come to your outpatient clinic and you can't talk them down or calm them down? In our practice, we give them an injection, combination of haloperidol and promethazine, right? But when we did a systematic search, we found that lots of people were using different things. And the nice guideline said you should do lorazepam. So we said we will do this in a pragmatic way. So a pragmatic trial is done in real world settings during our routine working condition. It does not exclude all the large number of patients that the regular trials do. We said anybody who doctor feels needs an injection is included, unless the relatives say we don't want to take part. Okay, and then the outcomes we use are also of relevance to clinicians and caregivers. We did all the blinding and all that stuff, so the biases of selection are not there, right? Now, what is the relevant outcome? The common one everybody says you use the overt aggression scale, but nobody in the real world uses it. So we chose outcomes by asking our clinicians, what outcome do you want? And they all said, see, we've got 400 patients waiting in the outpatient. I'm going to sit here and spend so much time. Everybody is going to be inconvenienced. I want this guy out in 15 minutes. And we said, what do you mean by out? So we finally discussed, and our outcomes were tranquil, that is not disturbing anybody, or asleep at 15 minutes after the injection. And they also said he must be like that for 4 hours, so when I come back, I can take care of him. We also asked the relatives in a different study, what kind of outcome do you want when you bring disturbed patients to us? And all of them said, this outcome we are looking at is my relative has not slept for so long. If you're only sleep, everything will be fine. So that's why we chose these outcomes. Outcomes important for the users, not for researchers. And when we actually sent for publication, both the journal peer reviewers said, why didn't you use the overt aggression scale? So we said, you show us any clinician who uses the overt aggression scale in real life, and we'll withdraw the study. Obviously, they couldn't, they published it. Interestingly, after the first trial, when the NICE guidelines came out on violence, they said IM, haloperidol, and promethazine is used elsewhere, but we have not used it. It's shown to be safe, but we cannot recommend it because we don't use it. Interesting. But when the update of this guideline came, after both our trials had been published, now they say you can use either IM lorazepam on its own or intramuscular haloperidol compared with promethazine for rapid tranquilization. Just to show that the river of evidence now flows both ways. Till now, we used to sit and say, you give us the evidence. We are now saying we can provide the evidence which can be used elsewhere. Thank you very much. That's the extent of my talk. I've got a few minutes left. Is there any doubts that you have right now? Or you can email me. My email address is Prathap Tharyan, Pratharyan, single word. I can actually show you the spelling from the first slide that I have here, in all small letters at gmail.com. Prathap Tharyan, and keep in mind there's a TH here. Most people spell Prathap P-R-A-T-A-P, but I use P-R-A-T-H-A-P, the South Indian spelling of Prathap. So you can mail me and I'll be happy to answer you. I'm coming back in about a couple of weeks from now, and we'll talk a lot more about systematic reviews. But if you have any doubts on this particular topic, please email me and I'll send you references. So that's the name, all small letters joined. Right? Can you see that? Prathap Tharyan, P-R-A-T-H-A-P, all small letters. Is that okay? Anything else? Anyway, I look forward to your emails. Thank you very much. Great. Take care. Have a good day.